The second presenter is Dr. Fikadu Ayenacho. He is Medical Director of Hamlin Fistula Hospital. He will talk about urological injuries following obstetric and gynecological surgeries.
And thank you very much for the Executive Board of ESOG to give me this chance to speak on this, I think, very critical issue in the practice of obstetrics and gynecology. And my objectives in this presentation would be more like giving you an account of the global picture of what urological injuries in general would be, and also taking the practice of obstetric fistula and treatment of obstetric fistula as a proxy for urological injuries in practice of obstetrics and gynecology in the low resource settings. I would like to also implore you to listen to my presentation in the perspective. So just to start with giving you an account of the very critical, I think, important anatomical considerations in the urinary tract. The urinary tract, when it comes to getting injured, can happen at any site, starting from the kidney, low into the ureters and the urinary bladder. Because we are practicing in the pelvis, most of the time we are also exposed to the lower third of the ureter. But now we are also doing a lot of oncological surgeries, as we didn't do before, and so the middle third of the ureter is also at a risk. And I also want to note here that the ureters get their blood supply along their course, and this is also very critical, I think, to the laparoscopic surgeon, because of attention should be given in terms of operating laparoscopically when it comes to electrocauterization. So many studies have shown that the most common site of injury to the ureter is around its entrance into the pelvis, and very close to its entrance into the bladder, and crosses the cardinal ligament and passes to the bladder. When it comes to the kidneys, because we are gynecologists, we actually don't come closer to the kidneys. But as I said, sometimes when you operate on big tumors, retroperitoneal tumors, metastasized tumors, then there is a risk that the kidneys can get injury directly, primarily. But most of the time from our surgeries, the kidneys get injured because they get problems secondarily from damaged ureters or damaged bladder. And what I would like to emphasize is gynecologists are more on to repairing the bladder as an anatomical organ, but it has a very important function of modulating the pressure that the kidney should be functioning in the range with. So whatever we do to the bladder, we always have to remember that there is going to be an affection to the way the kidneys function. And as I said, the ureters and the bladders are commonly the organs that gets injured. The bladder is more commonly injured during gynecologic surgeries. Studies say between the range of 4:1 or 5:1 to the bladder into the ureters. But the most common injury to the ureters is ligation. This is consistently been seen in many studies. But unknowingly, the common other type of injury we induce is kinking to the ureters by putting our sutures, cleaves, and cauterizing the ureter. And if we are not the vigilant surgeon, these are the injuries that manifest later after the patient is discharged. And these are the patients that usually account for more proportion of uteric injuries than direct injuries to the ureter. So it's always also very important to consider having the risks for ureteric and bladder injury. But what I want to note here is we have to all think our patients having the risk to get bladder and injury once we open the abdomen and we go for a pelvic surgery. it's not only those patients with big masses, distorted anatomy, or congenital anatomy, abnormalities, or patients we operate on with malignancies that have risks for ureter and bladder injury. We have to consider all patients we operate in their pelvis are at risk of getting ureteric injuries. So looking at the literature, there is a wide range of estimation of the occurrence of urinary tract injuries. So it ranges between 0.2 to 4.3%. And this also depends on how vigilant you are and how focused you are to look for these injuries. So it depends on whether somebody does a cystoscope after surgery, intraoperatively, or you don't do cystoscopy after surgery or intraoperatively. So you can see if you do cystoscopies routinely, then you can detect more ureter and bladder injuries than you would detect ureter and bladder injuries by only looking at or taking your clinical judgment. And there are no good studies in the developing world, but if you look at details of the type of surgeries that cause ureter and bladder injuries, of course, radical abdominal hysterectomies and laparoscopy-assisted vaginal hysterectomies always come on top. And cesarean sections, even if they are done in many numbers in the developed world, they come least they come on the low, least on priorities. But you look at as I said, the numbers from developing in low resource settings, there are no good studies, but I could get only one done in Nigeria from a medical school, and their estimates were about 3.6 per thousand. And recently there was also another publication from Tanzania, and their estimates were about 7.3%. So you can see how big differences in terms of the occurrence of urological injuries. But looking at also evidences about high fistulas, intracervical and ureteric fistulas reported from mainly fistula surgeons. What's different about the occurrence of urological and ureteric injuries in the developing world is they commonly happen following obstetric indications and obstetric surgeries, not gynecologic surgeries. It could be that we do a lot of obstetric surgeries. It could be that we don't do a lot of, invasive gynecology and difficult surgeries. But at the same time, we also need to think that, as I said, the evidence show that urinary tract injuries should occur the least with cesarean section. Well, what should be noted here probably is the issue of task shifting, and also, the issue of training our surgeons, and also what kind of patients in the profile of women these surgeons get in the primary surgical units. It's usually women who come after hours and days of labor with distended lower segments and contused bladders and distended bladders, which are already a high risk for injury to the bladder and the ureters. So it means that the surgeon should take focus on how to prevent the occurrence of these injuries. And so looking at also some evidences from my hospital, the chart you see on the left is a pattern of our number of fistula, vesicovaginal fistulas over the last 4 years till 2015. The rate of high vesicovaginal fistulas, including ureteric fistulas. And you can see that there is a trend in the decrement of genitourinary tract fistulas, but there is a trend in increase of the number of and proportion of ureterovaginal fistulas. And on your right is our experience 5 years with ureterovaginal fistulas, and you can clearly see the same kind of pattern. So even if the denominator is my own patients in the hospital, but I would say because my hospital is the one still comprehensively dealing with these fistulas, it should be a proxy indicator of what actually is happening out there. So for us, these are indications that we are having more and more ureterovaginal fistulas, and of course urological injuries are happening with gynecology and obstetric surgeries. So the best way to deal with this is prevention, okay? And there have been many studies which have tried to compare patients who have been catheterized their ureters before surgery and after surgery, and none of them have showed that this is the best way to prevent ureteric injuries. The only interventions preoperatively that have been shown with controlled evidence to show that there could be a better prevention of ureteric injuries is with light stents when you do laparoscopy surgeries. So otherwise, it's the surgeon, and the surgeon only, the vigilant surgeon, with the proper techniques in gynecologic surgery that can avoid the occurrence of urological injuries. And not surprisingly, even in the best setup, 50 to 70% of these injuries could be missed. So post-operative follow-up is also very critical. And with suspicion of ureteric injuries, particularly intraoperatively, for any reason, like you notice the ureter kinked, urine leaking from the bladder, or you see any distension from in the ureter, then you have to call for someone, or somebody who should be able to do cystoscopy should come and intervene. And in case that you don't have the services, the supplies, or the skills for cystoscopy and stenting, then ostomy is advised. And this has to be, I think, a routine practice for all of us, as I said, as practitioners and trainers. And post-operatively, all of the patients don't show the typical sign of flank pain. And this is because ureteric injuries can be, as I said, different types. So it's not like you always occlude the ureter. It could be partially injured. It could be completely cut off. So in case you see, and then, you know, the leakage of urine could also be retroperitoneal. So it all, again, depends on the vigilant surgeon to pick signs of possible ureteric and bladder injury post-operatively and try to diagnose and deal with them early. The main issue is, like, you detect bladder and ureter injuries early, and you deal them early. It means you improve on the outcome of renal function, the patient's outcome, clinical outcome, and the cost in terms of patient morbidity, as well as the burden you have to your clinic, is much less. So as I said, once this happens, and with complications to the urinary tract when they come very late, we'll be dealing with this audit of ureteric injuries tomorrow. I have the abstract to present. Anyone interested can come and we can have more technical discussions. But depends on the, as well as extent of injury of the urinary tract, and it needs a lot of reconstructive surgery. So the best way to deal with these injuries is to detect and treat them early. So in summary, what I would like to say is urology is uncommon. And we are now in where even the Ministry of Health is thinking of having cesarean section to go to a rate of 10 to 15% in the community. And we are a 90 million population country, so we should be looking at hundreds and thousands of cesarean sections to be done. So urological bladder injuries are inherent in pelvic surgery, and I feel like they are happening and occurring in higher rates than expected in Ethiopia. So I would say I would look at the rate of a number of patients coming with urological injuries. And diagnosing things early is the best way to occurrence of these injuries, as well as avoid the cost of treating these injuries. And always operating on patients in the pelvis, we should be very careful with the urinary tract and avoid urinary tract infection. None of us are immune from injury to the urinary bladder and to the ureter. It can happen to anyone, but acknowledging the injuries as they occur and trying to seek assistance, as well as managing them early, is, I think, very critical, because late diagnosis incurs a lot of cost in terms of, as I said, patient morbidity, as well as increasing the burden of treating these injuries to the health system. Thank you very much for your attention.
Thank you, Dr. Fakada. Some 10 to 15 years back, the institutional delivery in our country was about 5%. But now it has increased. It is between 50 and 60%. So the shift is now, there are less number of vesico-vaginal fistula secondary to obstructed labor. And because of the rise in cesarean section, and also more gynecological surgeons coming to the picture, more urological injuries are appearing. So thank you, Dr. Fakada, for bringing this into attention. It was really interesting presentation. The third presenter is Dr. Iyasu Mesfin. He is currently an instructor in Gynae Ops in Addis Ababa University. And also he served for about 4 years in ESOG as vice president. He will talk about increasing access to emergency surgery, the national ESO performance assessment preliminary result.
My presentation is a preliminary report of a national emergency surgical officers performance assessment, which was conducted in 2015 under the aegis of the Federal Ministry of Health and full funding from the CDC Ethiopia. This is the content of my presentation. This is a list of investigators. After its being launched in 2009, the first batch graduated and were deployed in 2012. And by the time this assessment was conducted, already 205 ASOs were deployed and practicing in the 96 facilities which are assessed under this assessment. The overall objective of this assessment was to assess the role of emergency surgical officers towards public health facility performance of CMOC and emergency surgical care services in the country, with three main group of specific objectives. One, to see the working environment. Do they have a favorable working environment to practice as they are trained or as they are expected to? And two, what is the change in volume of services after their deployment, and what is the quality of care that they are providing, or what is the level of their skill? Is it to the expectation? Assessing it indirectly through chart review. There was no direct assessment. So all health facilities in which health office, an ASO was deployed and practiced for at least 1 year were included in the assessment, and they were about 96 at the time of the assessment. And data was collected by a team of data collectors, 2 data collectors per team, one either OBGYN or surgeon, and one public health specialist. There were key operational definitions. We divided the facilities into 2, just for the sake of comparison, ASO only and ASO plus facilities. By ASO only, we mean facilities where only emergency surgical officers are deployed, where there are no OBGYN or surgeons. Satisfactory when specific item, equipment, or structure is found to be fully functional at the time of the assessment, and adequate supply when the supply is available in each area or room where it is found and when it is fully functional. With this, I will go to the findings. The assessment, as I've said, was conducted in 96 facilities. 63 of them were primary hospitals. Generally, totally 8 regions were involved, and 22 of them were general hospitals, while 4 were tertiary hospitals. The primary objective of emergency surgical officers is to be deployed in primary hospitals, but they were also deployed in general and tertiary hospitals. This is to show the human resource in terms of favorability. Emergency surgical officers' minimum requirement according to the national standard was 1, so 100% was fulfilled. And the good thing was the number of midwives, the minimum number of midwives required per facility was fully fulfilled in 100%. The minimum requirement was 4, but an average of 9 midwives were available, so that was a good outcome. But the number of anesthetists was relatively low. The minimum requirement is 2, but only 1 were there in about a third of facilities. This is just to reflect on the impact of their performance. When we see the infrastructure and basic service, radiologic services were not available in 33. It was available in 66.7% of the facilities. The problem was mainly significant in primary hospitals. In general hospitals, as you can see, it's available in almost all. The other critical problem for their service provision was the blood transfusion. Blood transfusion service was available in almost 80%, so it was not available in 1 out of 5 facilities. That could seriously affect the performance because blood is the cornerstone of emergency surgical services. And the other findings are as shown in the table. We have assessed all essential drugs, but I have included here only the key ones. And the serious problem in terms of availability at the time of the assessment was not that bad. But in terms of stock out or availability without stock out was a big challenge, especially magnesium sulfate. It was available without stock out only in a third of facilities, which is around 35.4%. And the other drugs, as you can see, even fluids, IV fluids, normal saline and ringer lactate, were not available without any stock out, as shown in the table. So there was a serious challenge there. For equipment and supplies, the picture is similar. As you know, hematology, clinical chemistry, machines need to be functional to properly manage complicated cases like hypertensive disorders and so on. But those were not available like in about half or more than half of the facilities. So that can also have its own effect on the performance. The other that we have seen is the signal, CMOC signal function service provision status. Looking at the 9 signal functions, none of the facilities were providing all the 9 signal functions continuously. So there were challenges. As we have mentioned, blood transfusion was the big problem. That I hope is addressed now because this finding was presented to the Federal Ministry of Health, and they have some actions. Now, when we see the change in volume of services, we selected certain service indicators, and a big increment in service indicators was seen. The biggest increase in volume was laparotomies, which increased the number of laparotomies for ruptured uterus, which increased by almost threefold, 285%, almost threefold increment. New antenatal care visits increased by about 28%. Cesarean delivery rate increased by 149%, almost 1.5-fold. Even contraception surgical tubal ligation increased by 180%, which is almost twice. So there was a significant increment in the volume of services provided after their deployment. Similarly, there was also improvement in the outcome. Facility level maternal deaths, proportion of maternal deaths has shown a decrement by about 38%, which is close to 40% at the facility level. We were able to find records of maternal deaths only in 63 of the 96 hospitals. So this reflects the performance of the 63 hospitals. Live birth rate increased by 9.25, and stillbirth rate decreased by 23.2%. And similarly, early neonatal days also showed a decrement of about 17%. This was seen as a good achievement. The other component that was analyzed was the skill, the clinical skill, clinical decision making and surgical skills of emergency surgical officers, assessing it indirectly through chart review, because our data collectors were high-level providers. They can judge the reviewing at the documentation, different documentations, medical records. One of the areas that was evaluated was the documentation, quality of documentation. That was a very serious problem. Documentation was very poor. I think this is a cross-cutting national problem. We saw at the minimum national standard, and only around 50%, 51% fulfilled the minimum national requirement for evaluation. But after admission, the follow-up, the operation note, quality and completeness decreases significantly, as you can see, from 51 to 30 and then 28.6. This also needs attention. Now, the other way that we used to evaluate their skill indirectly was to look at the documented surgical complications. The undocumented ones, we don't know, but we focused only on the documented ones. So the excessive hemorrhage was the commonest complication, which was seen in about 35, which comprises 35.6% of the reported complications, which are about 135. About 135 complications were analyzed. So excessive hemorrhage was top in the list, followed by deep incision extension. The other interesting area was wound infection and dehiscence rate. It was 11.9, but in SO only facilities, compared to SO plus facilities, it was about 3 times higher, which reflects possible gap in infection prevention and skill, which is an area of improvement. Generally, the complications were assessed to be avoidable by the data collector team in 80.7% of cases. But the management that was provided after the complications were occurred was seen or evaluated to be appropriate in the majority, in 86.3%. The other area was maternal days review. Around 170 maternal days were reviewed, and appropriate intervention, according to the data collector team, was provided in 55.8% and 63.8% of cases in SO and only and SO plus facilities respectively. Patient delay was seen to be the most important factor for the maternal days, but up to 16.3% was due to delay in the facility level delays. The commonest, the most important cause of death was hypovolemic shock, followed by hypertensive disorders of pregnancy. In conclusion, deployment of SOs in all health facilities has resulted in a remarkable increase in volume of MNH and emergency services, which means it has increased access to emergency surgical CMOC and emergency surgical care services. But there are also many challenges identified, the most important being shortage of blood transfusion services, shortage of important equipments and supplies required for surgery, witnessed gaps in clinical and surgical skills, and reported unsatisfactory duty payment and incentives by the health officers based on their interview. So the recommendation was for all stakeholders in collaboration with the Federal Ministry of Health to fill all the identified gaps to maintain to improve the gains of the program, and strengthen pre-service training and subsequent post-deployment continuous focused surgical skill building support or mentoring after their deployment. So that was the recommendation. Thank you for every partner which was involved in the assessment. Thank you for listening.
Thank you, Dr. Iyasu. My apologies, Dr. Barbara. I skipped the presentation. It was unintentional. So I call upon Dr. Barbara, who is the Vice President of Health Policy, the American College of Obstetricians and Gynecologists. She will present about non-gynecological injuries following obstetric and gynecological surgeries.
No offense taken. It's actually very, very interesting and an important talk. So very briefly, we're going to go over all of the other complications of surgery besides urologic injuries, and there are quite a large number of them. In fact, one of our very famous authors in the United States is Mark Twain, and he said it's amazing what little harm we do, given all the opportunity we have to cause harm. So as surgeons, we know that it's a daunting task to open the belly and to operate in the pelvis. And so we'll talk briefly about what those things are. We have to think about the whole woman, not just the pelvis, when we think about complications. So there are cardiopulmonary complications that we should not forget about. There's respiratory failure. Certainly the infectious complications, bleeding, unintended injury, and we talked a little bit about that already. Thromboembolism, blood clots to the lungs and death related to that. Wound problems and anesthesia complications, and particularly when we're doing surgery in rural areas with anesthetists or trying to do emergency surgery, anesthetic complications are also things that we as the surgeon, because we are controlling the room, need to think about and pay attention to. The factors are many, related to the age of the patient, the size of the patient, the status of the patient, her nutritional status, whether she smokes, diabetes, as we're seeing more and more diabetics, and then malignancies or severe infections can also increase the complication rate. Risk factors that are related to us are inadequate training, as we just talked about, the equipment, major problem and major issue for us, an inconsistent team. So surgery is not just about the surgeon, but it's about the team that puts our equipment together, that's managing the room, that's managing the sterility of our equipment. All of that is important. Inexperience. We know that the rate of complications is higher in inexperienced surgeons. And then there's the rest of us with our overconfidence at times, that we always have to remember that each patient is unique, and we see something different every time we do an operation. So this is about thinking about surgery as a system, not as us individuals operating, but as the entire ecosystem of surgery. And that includes anesthesia, our equipment, getting the patient to us in time, giving the antibiotics, the right ones at the right time for the patient, making sure that we have blood available when we need it. All of those things contribute to good outcomes in our patients. And as we're thinking about quality improvement for surgical services, we really must think about the entire ecosystem of what we're providing. So the prevention is about engaging the entire team, ensuring that we as leaders in surgery are looking at the systems for sterility of the equipment, good water supply, that there's adequate drugs when we need them, that the oxytocics have been kept refrigerated as they need to be. All of those things we need to think about. We need to think about also conserving our resources, that for antibiotic prophylaxis we need 1 dose of a relatively inexpensive drug to give us the optimal outcomes. We need to be thinking about blood clots and how are we going to prevent those in our patients. Positioning the patient, so it's not just the scalpel that can cause an injury, but the injury can be by placing the patient in an improper position. Avoiding shaving things that can increase infection. Carefully tissue managing the tissue. So I talk to my residents about treating tissue as though the patient were awake and I were doing the operation under local anesthetic. Be very careful with how we manage and handle the tissue. Maintaining our equipment, that's a challenge. I will tell you it's a challenge in the US. It's not just here that that's a challenge. And planning, and more planning. Thinking through the operation in advance. We are like a sports team, if you think about it that way. It's easier to avoid something if you've thought about it in advance and thought about how to prevent it. So I want to go through, I know that you're beginning to do laparoscopy here in Ethiopia, and I want to show you some of the data on laparoscopic complications so that you're aware that you'll see more vascular injuries. You're going to see urinary tract injuries and bowel injuries related to the access to the abdomen using sharp instruments and trocars. So 57% of the complications and injuries in the Netherlands are related to that primary trocar insertion. That is the scariest time at which usually my heart rate is higher than the patient's and my blood pressure is significantly higher than the patient's. And then 43% are during the procedure itself. And the factors associated are ones that you would expect: previous laparotomy, scarring, and inexperience of the surgeon. There's a learning curve no matter what we do. What I would like to share with you is that we can think about these things in advance and try to accelerate that learning curve so that we reduce the number of complications. Positioning, particularly for laparoscopic surgery, is very important, and we need to ensure that we've thought about injuries at the shoulder, at the arms, at the legs, and that the positioning is appropriate to avoid pressure points on nerves. So we don't want to hyper-abduct the legs. We don't want to hyper-flex them. We want to make sure that we have wrapped the elbows and the knees so that the nerves are not exposed, and that we need to avoid shoulder braces. Brachial plexus injuries are actually not all that uncommon, particularly in robotic surgery. So I know we're not going there today, but shoulder braces are some things we'd like to avoid. And when we're doing open surgery, we can damage nerves with self-retaining retractors. So we can injure the obturator nerve, and we need to be careful about how we place retractors as well. The access, as I said, is really a problem with laparoscopic surgery, and the overall incidence of injury is about 0.18%, but it's higher when you do what's called closed laparoscopy, means putting the trocar in without dissection first, versus open laparoscopy. So I would encourage us in Ethiopia to learn open laparoscopy. It, in my mind, is a much safer procedure, and we're used to doing that when we open the belly for laparotomy. We can avoid sticking that trocar in blindly. That's the scariest part of any operation, is that blind stick. So we can end up with all kinds of complications related to that. You get some of the gas in the subcutaneous tissue. It can dissect around to the neck. It can actually obstruct the breathing. You can get too much carbon dioxide, and the patients have a reduced O2. The vascular injury is a problem. Gastrointestinal injury, injuring stuck bowel that's stuck underneath the umbilicus can be a problem, and urinary tract injuries as well. So the access can be in the abdominal wall, it can be in intraperitoneal vessels or retroperitoneal vessels. What are the scariest ones? The retroperitoneal vessels, especially if you hit that with a needle and you hit a vein. So the pressure, the intraperitoneal pressure at laparoscopy can hide a large hematoma in a vein, and she's not going to show us any signs at all until she's in the recovery room. And you've released the pressure, you've taken her out of Trendelenburg, and now all of a sudden she collapses. So those are very frightening. The anterior abdominal wall vessels, if you're disciplined, you can find them, look for them, and avoid them. But I'll show you a picture of what that looks like when you get inside. it's a little frightening. You see this wall of blood coming down towards your camera. It's not all that difficult, though, to find the epigastric vessels and occlude them. The intraperitoneal vessel is really that as you begin to do laparoscopic surgery, we tend not to be as careful with tissue because we're operating at a distance, so we don't have the same haptics that we do when we do open surgery. And we used to call it the rip and tear technique, is not what you want to do. It's very easy to damage veins, particularly as you're trying to do retroperitoneal dissection and intraperitoneal dissection. So desiccate before you cut, don't yank and tear the tissue, change out instruments if you need to, and maintain the instruments. One of the most challenging things with laparoscopy is keeping the scissors sharp. They tend to get very dull very quickly. And then prior to closure, reduce the pressure in the abdomen and look carefully. And think and plan and say what's going on in the retroperitoneum. Is there an expanding hematoma back there that I missed because I had the pressure up there? Are there smaller vessels around the cervix that are bleeding now because I've reduced the pressure? So very important to look for that. The retroperitoneal vessels are the most frightening. The deaths that we've seen in the United States are related to trocar injuries to the aorta, to the iliac vessels, and those are not that hard to hit. And what you see, this is an old study, but because most surgeons are right-handed, the right common iliac artery is the most commonly injured vessel at the time of primary trocar injury. And that vessel, I will tell you, bleeds a lot. And if you do not have a vascular surgeon close by, she can bleed out before you can get help. So what's the answer to that? Open the patient the minute you see something like that. Don't try to manage it laparoscopically. So we talked a little bit about patient positioning. What about gastrointestinal injury? Why is that more common at laparoscopy? We're using different types of instruments, and we're trying to avoid suturing laparoscopically because it's difficult. It's a hard technique to learn, and so the likelihood is that we're using electrosurgical energy, and when we use electrosurgical energy in a narrow, focused field, there can be energy that is injuring the bowel that we don't see. It's outside our operative field, and it's injuring the bowel serosa. So it's one thing when you're watching what you're doing and you're directly injuring the bowel. It's quite another when you've got a piece of bowel here, your focal point is here, and your scope is touching the bowel and discharging electrosurgical energy. So it's something to be aware of when the patient comes back a few days later. It could be a ureteral injury or it could be a bowel injury. Rule of thumb, laparoscopic patients should feel better and better each day. If she is feeling worse for any reason, there's a problem. And it's a big problem, not a small problem. So injuries to the bowel can be far deeper than we can see. And if you see an area of whitish bowel, know that you need to resect that. Because even if it looks okay at the time of your original surgery, the likelihood is that that damage is much broader than you see, and it will necrose, and over 3 to 5 days, you will have a big hole in the bowel. So we want to avoid that. We also want to avoid using too much energy voltage. So the voltage is the pressure of electrons that are going through the instrument. Using coag current, when you see that on your electrosurgical unit, pushes more energy into your instrument, and it's a higher risk of damage. Using the cutting current will give you less flow of electricity and less likelihood for damage. So lots of opportunity there to cause harm. The breadth and the depth of the tissue injury depends on the unit you have, how sophisticated your equipment is, how long your instrument's been in contact with the bowel, and how large an instrument that you're using. So, what do you do to minimize the risk of injury? Knowing your anatomy, position the patient properly, make your incisions big enough so that you can put your trocars in without getting stuck in the tissue. traction, counter-traction, the same things that we use in major surgery, recognize high-risk situations and think in advance about what they are. All of these things can happen, and we need to avoid them. Nerve injuries can happen with dissection. The instruments that we're using for laparoscopy are not what we're used to at open surgery, and we must practice with the equipment in advance so that we know how much pressure to use, what size vessel can be occluded with a bipolar desiccation, and what size vessel do we have to suture. We need to know all of those things in order to avoid injuries. And then wound management, we don't want to see the dehiscence. We want to make sure that we're using antibiotics appropriately to avoid surgical site infections. Most of these injuries are avoidable if we can think in advance, if we engage our teams, if we think about who the right patients are for the surgery that we're doing, and that we try to reduce medical morbidities as much as possible, increasing the nutrition for our patients. Carefully position and plan our patients, know the anatomy, understand those energy sources because that's critically important in laparoscopy. Have backup equipment if you can, and always have laparotomy as your backup because that's really an important tool for safety for our patients. Never promise them that we're going to do surgery in a minimally invasive way. And create a highly reliable team that practices together. Think the worst because you may save your patient's life. When she comes back and she's got a complaint, we have to listen to her. Experience is the name everyone gives to their mistakes. We all make them. Our job is to learn from them. I thank you very much.
Thank you, Dr. Barbara, for the nice presentation. We have last but not least presentation. It is about the current state of safe essential surgical care in Ethiopia. It will be presented by Dr. Ibelt Al-Mokonnen. He is a director, Clinical Service Directorate of Federal Ministry of Health. Dr. Ibeltal.
I think it's 6:15, so it will be the afternoon. A lot has been said about the quality of maternal care services, so I'm going to have a brief presentation. First of all, I will discuss a little bit about the summary of health indicators and also health service indicators for Ethiopia for the past 20 years, and then I will proceed with Ethiopia's response for the current challenges. This is my presentation outline. So we'll have a bit of a background, and we'll talk a little bit about national strategies and priority interventions. We'll talk about maternal health indicators and also the gaps to reach them. As you all know, there have been a lot of initiatives to improve the maternal health services, and there have been a lot of international commitments. I'm not going to go through to the details of them. We also committed for MDGs, and we said that we were going to reduce the maternal mortality rate by 2/3. So we had 20 years rolling of HSDP, or the Health Sector Development Plan. And we also had another round, which was a National Reproductive Health Strategy from 2006 to 2015. Its priorities were to improve the proportion of fetal births attained by skilled health personnel, and also to upgrade the status of women through education and also empowerment. We also plan to reach the community, so we have rolled out the health extension program in 2003 and 2005. This actually had provision of family planning at the lowest level, that is at household and health post as well, and also providing clean and safe health delivery at homes. Looking at the current status, there is a high commitment from the government, and there is also community engagement through Women Development Group and also the Health Development Armies. We have started building maternal waiting homes, and from the last EMOC assessment, there were around 45% maternal waiting homes were available in primary care facilities. Ambulance services have been also expanded for Waredas, and we have also started we have expanded on the safe blood transfusion as well to address the different